So, what we're going to talk about today is shouldn't treatment work and how we assess treatment. And I think that this is not something we think about often enough, and I think we need to think about it more. So when I'm talking about a general scheme for humane care, I'm going a little further than we normally go in veterinary behavioral medicine interventions. And I'm going to talk about what we normally do next. But I want there to be no scary or abusive interventions, which may include most punishment as it's currently and usually practiced. I want people to really protect the patient because they're emotionally and mentally fragile, and I want their specific and often very special needs to be met. And I want people to modify what they can in the physical and social environments, which is where the first set of behavioral medicine guidance usually kicks in. But I want people to do this so that the patient is less concerned and reactive in general, because that affects their ability to learn. And I want them to do it in a way that the patient can actually help to create or participate in their own recovery strategy. In other words, I want us to create a milieu where the patient can learn from what's going on, how they can best deal with things. These two are not the same, and they're not usually explicitly addressed in standard modify the environment, modify the behavior programs. I am very, very concerned about what's happening at the neuromolecular basis and how they're learning, and we want them to learn adaptive skills. We don't want them to just learn to not display the distressed behavior without a better strategy in place that allows them to be who they are. And really, to have this come about, we have to modify the mental, behavioral, emotional environment. And this is always included in the standard approaches. The standard approaches talk about avoidance just simply so that you don't trigger the response. Inherent in that is that downstream stuff I just talked about, but it's almost never made explicit. People are mostly worried about reinforcing the distress and the responses that are already learned. Environmental modification generally means altering access. It could be more, it could be less. Make sure the visual and auditory environments are fairly calm, provide a more calming, more engaged environment. We don't tend to think about that enough. Sounds, lighting, physical comfort, toys, maybe interactive devices like furbos or treat and trains. And people are pretty familiar with using behavior modification, which is primarily operant conditioning approaches involving desensitization and counter conditioning and some classical approaches. But people are not as familiar with some of the cognitive approaches, but they're all reward-based approaches, at least in this field, from specialists. That may not be the case if it's not a specialist in veterinary behavioral medicine. And the focus of the talk today is really going to be the latter, pharmaceutical and neurochemical modifications. So we don't just want to modify the neurochemicals that are floating around in their body. We actually want to modify these at the molecular basis, and we may need pharmaceuticals to do this. And we're going to talk about roles for diet, supplement, and medication. So this is really going to be our focus. And one of the reasons for that is I think the way I explained avoidance and meeting needs, while maybe slightly different than most people are used to, is accessible. I think we need to enhance the way we think about environmental modification, and we need to go further in behavior mod. But there aren't a lot of data for those. And pretty much everything that we know about effects of behavior modification, you can get from the rodent literature. We know a heck of a lot more about operant conditioning and classical conditioning approaches from the rodent literature than we do from dogs. There just aren't that many data. We know that reward-based techniques work faster and better than punishment techniques in acquiring a new behavior, and that they seem to allow you to retain it a little better, but the data are pretty sparse. So we're going to talk about neurochemical modification. And I want to talk about evaluating efficacy, because this is something, especially for the veterinarians in the audience, that I think is critical. If clients knew what was behind this, they would think this was more important than anything else we do. But veterinarians somehow forget their role in questioning whether or not something works, because we get wrapped up in the idea that something is licensed, something's not licensed, and we're treating patients. So what I'd like to do is give this some critical thought, and we're going to review the common medications. We're going to talk about the published studies. We're going to talk about what's known about nutraceuticals and supplements, and in the context of peer-reviewed publications. And we're going to give an overview of prescription diets, which is where you're going to find the information on effects on behavior and their basic findings. And in order for me to consider this in the review that I put together today, all of the compounds have to have an established mechanism of action. It may not be their final one, but there had to be a mechanism of action that everybody could agree on. And this is why I left out the pheromonal products, because they don't actually have one. And the data must be from the peer-reviewed literature, okay? So the common drugs that those of us who are in this field use, and again, medication is the purview of veterinarians and the people who are going to be most familiar and comfortable with and have the most expertise in using these medications are going to be specialists in behavioral medicine. But many practitioners are getting more and more comfortable in using these. Certainly, in order to give drugs, you have to have a license to practice medicine. And I'm only saying this because there's been some debate recently about concerns that people who aren't veterinarians are recommending medication. There's nothing wrong with saying, maybe you should talk to your veterinarian about medication. There is something wrong with somebody who doesn't have the expertise and the licensing criteria telling veterinarians what to prescribe. So there's a big difference there. So let's talk about benzodiazepines briefly, and I'm just going to rattle through these, and you're going to have the slides so that you can go back. Benzos work by stimulating inhibition. So the gamma aminobutyric acid receptors are inhibitory receptors and inhibitory neurons, and they tend to counterbalance the effects of the excitatory neurotransmitter glutamate. And they either inhibit a response or they modulate it. And that very much depends on both the situation and the individual patient. So they may not actually completely inhibit, you may get a diminution in the response. The commonly used medications in our field are the ones that are in blue. Lorazepam is short-acting, alprazolam is short to medium-acting, and clonazepam is a long-acting benzodiazepam. But these are used to inhibit or modulate a response by damping down an excited response, which is why they're also used as ancillary drugs in epilepsy. Gabapentinoids, this is an example of a drug that had a putative mechanism of action when it was created. It was meant to be a synthetic benzodiazepine analog. And turns out that about a decade ago, when we figured out how this medication works, it doesn't act as a benzodiazepine analog at all. Instead, it binds with subunits of calcium channels on inhibitory neurons. They may be sitting in the region of the GABA A receptor, but I'm not necessarily convinced that that has anything to do with it. And when you bind with the calcium channel, you have the inhibitory neuron fire and you damp down everything. So benzodiazepine receptors, GABA receptors are not directly involved in this, contrary to what they thought when they developed this drug. So we learn as we go forward. The two main gabapentinoids that everybody will be familiar with are gabapentin, which is Neurontin, and pregabalin, which is Lyrica. And the one commonly used in veterinary medicine is gabapentin, although people are beginning to see pregabalin prescribed a little bit more often. Notice that to date, I have not talked about a single drug that is licensed for use in dogs or cats. Imepitoin is the first medication we're going to discuss that is licensed for use in dogs. It's not widely available yet, but it is licensed. And it has some structural similarity to phenytoin, which is an anti-epilepsy compound. It's an midazoline derivative, and it has low affinity partial agonist capabilities at the benzodiazepine site. So it actually affects the GABA A receptor at the site where the inhibition occurs. It's also a dosage-dependent blocker of the calcium channel, so there may be two modes of action here. It may work a little bit like a benzo, and it may work a little bit like a gabapentinoid. And again, with new medications, you know, the lesson of the gabapentinoids is we really don't know how some of these medications work. And when we talk about TCAs and SSRIs, I'm going to make that clear. Alpha-2 agonists abort or prevent the initial burst of norepinephrine from the locus coeruleus as part of the arousal trigger for the sympathetic response. Sorry, my throat has been croaking all day. And the common ones with which you'll be familiar are clonidine, and the relatively newly licensed in the past couple of years medication, and it's not everywhere in the world, is Cilio, which is an oral transmucosal gel of dexmedetomidine, which most veterinarians and most clients will be familiar with as an injectable medication that we use to induce some very low level of sedation or as a pre-anesthetic medication. The tricyclic antidepressants were originally thought to largely affect norepinephrine with maybe small effects on serotonin, and the idea was that you just inhibited the reuptake of these compounds so that they were always hanging around ready to stimulate neuronal receptors whenever the receptors were available. And it was a simple equation of having more or less serotonin or noradrenaline, norepinephrine. And as it turns out, that's actually not the main mode by which they act. They actually modulate a response, and they do so by using neurotrophic effects, and they translate genetic codes so that you make more receptors and you make more of the functional parts of neurons. So really, they're a form of applied in vivo gene therapy where you turn on certain regions of the gene through a translational effect. And because of the regions of the brain in which you're going to find the serotonergic neurons, they promote the learning of new behaviors and the acquisition of newly learned behaviors, which is not what anybody expected when they were developed 50 years ago. So the common ones we use are nortriptyline, amitriptyline, and there is one that has a canine license, clomicalm, clomipramine, and we're going to be talking about this medication too. And with the SSRIs, the situation's the same. They modulate the response. And to a lesser extent than the TCAs, they affect noradrenaline. They primarily affect serotonin, 5-HT. But the idea was you increase serotonin in the regions of the brain. This is the regions of the brain that are involved in anxiety. You increase serotonin. The dog or the cat is, or the human is less anxious because they have more serotonin. And in fact, if all you do is increase serotonin, you're likely to make things far more anxious because there's an activating effect of the serotonin compound itself. But if what you do is you make the neuronal efficiency better and that they can transcribe new protein better, you facilitate making receptors and cell components that are the first step to acquiring and storing newly learned behaviors. And it's not a surprise that the person who figured this out, Eric Kandel, he figured out how we do the learning and the storing of it, got the Nobel Prize for Medicine in 2000. So nothing is as we thought. Fluoxetine has a label for dogs and cats in some countries in Australia. And the common ones that most people are using, they'll use all of these. You're going to start to see escitalopram used more frequently because there is a dosage determination study published in dogs, so people feel very confident about that, although it does not have a license for use in dogs. So let's talk about efficacy data. And what I would like to do, and I want to leave a considerable amount of time for questions today because I think there might be some. I'm going to pitch some of this in an atypical way. What I would like to do is just walk you through the data papers and walk you through good points and concerns and and explain why I think these are the types of things we need to discuss with our clients, because I don't think our clients really have access to our understanding. And at least in my situation, my clients are outrageously compliant, but they're compliant in part because we discuss all of these things and they understand them. And I take advantage of the fact that they're interested in what's happening, and that possibly augments their willingness to help their dogs. So when we're talking about efficacy, we're talking about whether or not something works. Now, the difference between supplements and diets and medications is medications everywhere go through some sort of regulatory concern. And the regulatory agencies have at the top of their list, does this kill off people and or animals, and does it work in people and or animals? It's pretty easy to determine that you're not killing off something, but certainly you do have to provide accurate advice on the adverse events that could be seen, and you have to prove that this works at some level. So what does working mean? Well, minimally, it means that you need a putative mechanism of action that makes sense, in our case, behaviorally, at some testable mechanistic level. So in other words, you have to be able to prove to this group of scientists that, in fact, you think this is going to change X, and by doing Y, you can measure the changes in X. So the things you might do are look at are changes in receptor function that's detectable by some kind of imaging, or quantitative changes in behavior that are statistically significant and in the direction that you predicted beforehand, or significant hormonal level changes in the direction you predicted beforehand. That the mechanisms involved in learning theory all play out in the direction that you predicted beforehand. Notice what you don't get to do is you don't get to go on a fishing expedition. You don't get to see, well, I just want to see if this works and we'll see what it changes. No, you have to have a hypothesis that you're going to test. A preferred way of knowing that something works is a known and tested mechanism of action. So in other words, if you really know a lot about this medication, you can say, well, we know it does X, Y, and Z. It affects serotonin. It affects translational learning, except there may be revisions to this the more we learn. We knew that the TCAs and SSRIs affected serotonin. We did not know they affected translational learning. And then your best way of doing this actually is the randomized double-blinded placebo-controlled study with a sample size that meets the prediction of the power of the test. In other words, do I have enough animals or humans enrolled in this study to be able to know what I'm talking about? And that then undergoes rigorous peer-reviewed data to be published. And the conclusions of that peer review must meet the scientific standards of interpretation and be maintained post-publication. So in other words, you generally look at this over a 5-year period. There is a continued reporting cycle, and people at places like the FDA keep a list of all the adverse events that anybody's reported. Is that in line with what you've published? And are people finding that the efficacy data are in line with what you published? And there are occasions where you suddenly realize a medication is gone because it's not living up to what everybody thought was going to happen. So we have efficacy data for Clomicalm, which is clomipramine, Reconcile, which is fluoxetine, Cilio, which is OTM dexmedetomidine, Pexion, which is imepitoin, and Trazadone, which does not have a veterinary license, but is widely used in veterinary medicine. So let's talk about clomipramine first. And this was the first drug that was licensed for use for behavioral conditions in dogs. I am not unbiased. Notice that that's my name. This was the first study that was published on that. And the way this study was carried out, it was carried out at a baseline at day 28, day 56, and day 84. So there was a baseline that was an evaluation. The dogs then were evaluated in a placebo-controlled, double-blinded manner at days 28, 56, 84, 3 months of treatment. It was a randomized study. Everybody got randomized to the treatment groups. I was blind. It was coded. Everybody who evaluated the data were blind. The data weren't even unblinded until the initial analysis had occurred and you got to the point where you needed to know which group everybody was in. And I'm just going to talk about some of the main findings. So these are the destruction. We had the following categories. The dog was worse. The dog was no change, which is 0 change. They were improved or it disappeared. So this is 100%. And these were some of the intermediate categories. So this is really a 4-point scale. They got worse. There was no change. They got better. They became relatively normal, a phrase that none of us would really use. And if you look at this at a month, and this is for destruction, you got a significant effect for improvement, and the effect was greater percentage-wise for the high dose. This is how these drug studies are usually done. You have a placebo, you have a low dose, you have a higher dose. So this also acts as a dose determination study for people who've never done these. And you see that the higher dose had a slightly better effect. By day 56, the higher dose maintained that. And by day 84, interestingly enough, this is common finding, people get really, really happy when things get better. And there was some passive behavior modification involved in this and some other maintenance things. And after things get into about this level, this 90% level of getting better, people slack off a little bit. And this may not be statistically different, and it's not actually statistically different here, but you're going to see this pattern in pretty much every study you look at. When we looked at defecation, we saw an even more profound effect. And that makes sense because clomipramine has anticholinergic effects. So you tighten the urinary sphincters, you tighten the bladder, you have less fluid. And so that's considered often an undesirable effect, but it helped out in the effects, in evaluating the effects of the signs that are involved in separation anxiety, which are usually things like destruction, urination, salivation, defecation, vocalization, panting. We evaluated only the most obvious of those that clients could evaluate. Okay, so we also looked at urination and vocalization. And if you look at urination, again, the same types of patterns. When you look at vocalization, I want you to pay attention here because you could argue that, yes, you got a month-by-month effect, and then later on this month, you didn't get a big enough change for this to be significant. Overall, it was significant. But I want you to look here. There's only 1 month where you get an effect for vocalization. Vocalization is tough, and look at the percentages. The reason for this is vocalization is about social behavior. And we did very little to address the social behavior in this study. And while these drugs would have facilitated enhanced social behavior, the behavior mod program did not address that. Okay. Now let's look at the fluoxetine and reconcile studies. And there were a couple. And they again did a dosage determination study. So they had a range of medication dosages that they found to be effective. But they did this very differently, and there are a couple of major effects that we need to talk about. They only looked at these dogs over an 8-week period. They also constructed a scale that's a percentage scale, and while this was a placebo-controlled, double-blind, randomized study, a percentage improvement scale, and the indices were constructed by subtracting the percentage improved in the placebo group from the percentage improved in the treatment group. And in this case, they've graphed out the placebo group and they've graphed out the treatment group. And they've looked at this at every week or 2 period. So you can get individual effects in the incidence, what they call the incidence of improvement, which was a percentage, which can skew the way you look at some of the data. These aren't the raw data. The study I just showed you for Clomicalm used raw data. And when you look at destructive behavior, they have week-by-week changes. And when you look at the at vocalization, they also have week-by-week changes through week 8. Now, here's one of the problems. These medications exert their translational effects beginning at about weeks 3 to 5. And we generally don't consider either clomipramine or fluoxetine treatment failures until at least week 8, when you see no effect. And the reason that the clomipramine study went to 3 months is that's the standard in humans for these medications, because you tend to see the more profound effects involving learning, granted, of which no one took advantage, by the 3rd month. And this is the second paper in this study that presented the data slightly differently. And again, this is the percentage calculated as improvement minus the placebo percentage improvement, looking at it week by week, giving you some actual numbers. And you see that actually the placebo group did very well. The placebo group and the treatment groups here are much closer than they were for the Clomicon study. And in fact, you only get significant differences in 2 of these weeks. But it was still enough to allow this medication to be licensed. And maybe a longer study would have fleshed this out. When you look at the study that was done for Cilio, which is a more recent study, and again, I'm not unbiased, and I need to tell you, I've advised all of these studies, so I'm not unbiased for any of them. And you look at what was done here you've got, again, a randomized, placebo-controlled, double-blinded study, meaning nobody knew until the data were unblinded. All of these studies so far have been this way. You had 89 dogs in the treatment group and 93 dogs. That's just the way the assignments worked out with the dogs that drop out. And there were specific signs that we were asking the humans to evaluate. This was a treatment application for fears of noises. And the fear of noise evaluated was one that we knew would happen. It was New Year's Eve fireworks. Okay. And these were the types of things that we asked them to evaluate: panting, trembling, vocalizing, pacing, seeking people, trying to hide, trying to escape, freezing, refusing to eat foods, inappropriate urination and defecation, and salivating. And this study was done later when video cameras were more common, and you would say, well, or I would say, why didn't you just do the video behavior comparison? Because this occurred in the dark. And that was the single biggest drawback, is that by the time the fireworks went, one of the things people did was to keep the dogs in a more quiet area to try to calm them down, which was generally dark. And if you look at the signs that people reported most frequently, there was no difference in the placebo and the control groups for the signs. That's important, and everybody should check that. When you've randomized a study, well, there should be no difference in the signs. And I've looked at studies that come across my desk where people say, well, we randomized them. And then I realized the treatment group has the mildly affected dogs and the placebo group has the severely affected dogs. And no, you actually didn't. And that's a bias, and we can't do that. So when you look at the results here, about 72% of the dogs either had an excellent or good effect. And here, again, worse, no effect, so 0. But instead of just saying, yes, they got better to some extent, this was broken down into some effect versus, no, a really good effect. They're not perfect, but you've shoved them over onto that side. And what that did is it's a more discrete evaluation, because some effect was considered a treatment failure. So unless they did really well and were pushed onto the good side, they were excluded from a treatment success. And certainly there was a very large odds ratio here. And there was, these data were significant. So it really favored the treatment compound for noises. Emepitoin is the latest of these compounds to the market. It is sold under the brand name Paxium, where it is already released and where it is licensed. And it's been around for a while, but it's being looked at in terms of possibly being used as an anti-epileptic drug. And in this study, they compared phenobarb and emepitoin in one group of epileptic dogs, and they were shown to be equally effective, which is interesting because phenobarbital is generally considered the standard, and the way they evaluated them here, the dogs did equally well. So that strongly suggests, even though there was no placebo involved, that there may be an inhibitory mechanism of action that might have other applications. Hence, looking at it to affect and redress noise, fears, and phobias. So here what you're seeing is the effects, and this is the placebo group and this is the treatment group, and they did something very similar to the Cilio study. So you got worse, you had no effect, there was some effect, there was a good effect, and there was an excellent effect. And they didn't get the range of good and excellent effect that Cilio got, and they didn't get the range of excellent that Cilio got, but they got a statistically significant difference from the placebo group. And this was a medication that had to be given over 2 days. So they looked at a slightly different way to evaluate these. And they looked at them over a series of periods of time using a scale. But part of the things that were flagged by the regulatory agencies for this compound is that over 20% of the patients were still ataxic 24 hours afterwards, and over 10% of them were ataxic 48 hours afterwards. Now, here's the big problem with any drug that affects behavior. Is this a sedation effect, or is it an actual treatment effect? Okay, so in other words, we need dogs to be cognitively aware. People will tell you, I don't want my dog drugged. If they're panicking, we would all love to have our dogs drugged if it spared them grief. But when you're asking about, does this work, we need to know how it works. So sedation is considered undesirable, and ataxia is one of the components that you evaluate in sedation. And in the Cilio study, for example, we knew that this could be a problem because at high dosages, this is a medication that is used to sedate animals. So we had a series of evaluations to ask whether or not the animals were physically sedated and cognitively sedated, and they weren't. Here they may have been, and this has shown up in a couple of places, and we're going to talk about it. So when you go to investigate this drug for other applications, people looked at it to treat comorbid anxiety in idiopathic epilepsy, and there was no effect. And you can see here that if you looked at the before the treatment and after the treatment, and here each dog acted as its own control, there was no difference between statistically significant difference between the vast majority or any of these groups. And it's also being looked at as a treatment for generalized anxiety disorder. And they have found no effect on any of the behaviors, but they did find an effect on cortisol. So they did have a statistically significant effect on cortisol, but no behavioral changes. And if you look at the general behavioral score, you can see there are no differences, which suggests that this medication may be affecting the response to stress, and that some of the effect may be a sedation effect. Could also be an inhibitory effect, but we can't rule out that sedation effect. It's not an effect so far, probably on most of these behaviors. I'm going to finish up with the drugs by talking about Trazadone, because Trazadone is an interesting compound, and it's used by a lot of veterinarians. And it's unusual that a group actually does a placebo-controlled, double-blinded, randomized study on a medication that is not being taken for licensure. And the group at NC State actually did this in part because they published the first study on open-label uses of Trazadone. And what they found when they blinded this compound, and they used it for post-operative anxiety, primarily in orthopedic cases, because animals get anxious at confinement. If we can relieve their anxiety at confinement so they're not walking on their repaired knee, for example, they should get better more quickly and they should be happier. And they found that there was a difference in some of the behaviors, but the difference was for both the placebo and the treatment groups. And in fact, they found no effect effect on the behaviors. Now, what you have to know about Trazadone is that it's nonspecific. It affects a variety of receptor sites, but it doesn't have the anticholinergic effects we talked about affecting bladder and bowel function that clomipramine has. It can cause orthostatic hypertension in humans and ataxia in dogs. That's usually how that shows up in dogs. And in human medicine, it's considered a hypnotic in human psychiatry. The 5-HT receptors, 5-HT2A receptors affect movement. So clinical procedures or movement disorders, this may be an excellent medication. But in this controlled double-blind study, and these are really rare here, so the authors are to be applauded, there was no effect on any of the anxiety measures they used. The other thing is that because this isn't going to a regulatory agency, we still have no dose establishment studies on either dogs or cats. So for dogs, the dosage range is still huge. So some of these effects may be dose dependent. And at this point, if anybody's interested in going further, the next step is a series of dose establishment studies that are also randomized, placebo-controlled, and double-blinded. And you may find that at one of these dosages, you get a greater anxiety than a hypnotic effect, although it hasn't been found in humans. The big concern that most specialists are now raising is that veterinarians are giving this out like candy. And I've already told you that serotonin is not benign. Serotonin is activating, and it affects a number of serotonin receptors. And we're seeing cases of mild serotonin syndrome, and serotonin syndrome can kill an animal. So we're seeing highly aroused patients who are taking Trazadone at a high dose with a lot of other serotonin medications, and you can't mix and match carelessly. Okay, so let's talk a little bit about diets and supplements. And this is actually my neighbor's puppy, who happens to be my puppy's best buddy, even though one's an Aussie and one's a Great Pyrenees. They're sort of mismatched in every way possible, and they love each other. Okay, so the data for diets are better than the data for supplements, but the types of clinical trials needed to license medications just aren't used in these, as I've said. So when we talk about this, why do people wish to use supplements or diets? Well, with supplements especially, people believe they're safer. But that may not be true. If they're bioactive compounds, they may not, in fact, be safer. There's also resistance to medicalizing behavior. But my concern with that is nobody wants to medicalize normal behaviors or behaviors that are normal distress behaviors, even if we wish to relieve the distress. But you're leaving out in the cold, when this is your complaint, all of the true pathologies. And I don't believe that behavior is a continuum of normal. In the number of years I've been doing this and thousands of patients I have seen very few patients who come to me who don't have a true pathology. I do think that you need to do good medical workups on these guys, and we see some dogs that also have comorbid medical conditions, or maybe their medical condition is causing their behavioral condition, but that's not medicalizing behavior, that's practicing competent medicine. Most supplements lack any kind of trials, and that's our concern. I'm going to talk to you about the ones that have had some trials, and I want you to realize in a world where the placebo effect is 25 to 50%, we need to question whether or not clients should try supplements first, or whether they should use licensed medications that are known to have an effect. And I guess that would depend on how worried you are about these or how much you have this belief. And again, that's a mistaken belief that they're safer. And if you're doing this competently, you're not medicalizing behavior, so those two concerns should go away. Then you have to ask yourself, are we doing harm when we delay treatment? We're going to talk about that in some depth at the end. I'm going to rattle through these studies pretty quickly because you have them. The ones that we're going to talk about for nutraceuticals are the L-theanine studies, which is an analog of glutamic acid, which may inhibit the reuptake of the excitatory amino acid by affecting the glutamate transporter. We're going to talk about, and that shows up in a number of compounds. We're going to talk about Harmonies, which has magnolia in it, and we're going to talk about alpha-casozepine, which is structurally similar to the inhibitory neurotransmitter GABA and has an affinity for GABA A receptors and is also in the calm diet. Okay, so when you look at Anxitane, there are a number of studies, and I'm going to rattle through them, as I said. This group used a randomized block design. It was placebo controlled, but look at the sample size: 10 in the Anxitane group, 10 in the 10 in the placebo group, but it wasn't blinded. Okay, and behavior modification was for both groups, 3 sampling periods over 63 days, 15 behaviors assayed, and cortisol was measured. No change in cortisol by group. Some of the 15 behaviors may have decreased more in the Anxitane group, but the statistical analysis is inadequate to actually tell that, and both groups experienced a change. That would not get you in the door if this was a medication. Okay. Here's a study that looked at social fear in humans, and it looked at laboratory beagles, small sample sizes, because that's what you get when you need to choose animals exhibiting certain behaviors. So 5 and 5 in each group, which is enough to make the authors of this study sort of pale. It was blinded only to those collecting the data, not those analyzing the data, but it was randomized. They used activity, open field, and human contact tests. There was no change in the groups for activity, no change in the open field. 4 of the human contact measures that were listed are here. The frequency of approaches, no change. Mean duration of time spent near a human. Both groups showed significant reductions, but in a non-parametric small sample size test, and the small sample size is the killer here. That's what's going to determine whether you want to believe these results. There was a difference. The frequency of interaction, there was a difference, but both groups showed significant reductions, and the time they spent with humans, both groups showed significant reductions, but again, a significant sample. Desensitization can't be discounted here. The authors are very, very honest about this. It's an inadequate design to test individual effects because of the way they did it. This is probably enough to say we should do a better study in a population that we can carry out the right design in. This is an open label study for fear of storms, only 18 dogs. There was passive behavior mod. They used 11 behaviors on a 5-point scale, and they rated the storm severity, because that matters, on a 5-point scale. There was a significant decrease in global anxiety and return to baseline after 5 storms. The problem is there was no placebo comparison, and that could have been a habituation effect. 5 of 11 behaviors showed some changes that were greater than 70%, but there was no analysis accompanying this. Here's another open label trial that looked at Anxitane and emotional stress in cats, 33 privately owned cats. They were scored as on a 0 to 3 scale, or 0 to 2. The data weren't actually presented, so nobody could replicate this study. They said there was a decrease in the interquartile interval from days 0 to 30 in a Friedman test. They had a hypervigilance score decrease, but there were small samples, open label trial, no comparison group, no placebo. This could have been habituation. And I'm going to close with a quote from that study, because this is a study that I hope everybody's saying, but that could have happened anyway. When people looked at harmonies, it was blinded, it was placebo controlled, a single crossover design, 10 dogs in each group. There was an effect only on inactivity in one phase that they measured, a weak effect. Should you go ahead? Maybe. You'd have to do a much bigger study, and it would have to be better designed. Xylkine, 2 studies done by the same group, randomized, double-blinded, multi-center for the dog study, 38 dogs, 19 in each treatment group. They used a European score, anxiety scale, and they did get a decrease. They used owner assessment at days 1 and 56, but they didn't do a placebo. They compared this to selegiline, which is a monoamine oxidase inhibitor that's frequently used, and they found out the effect is equivalent. And what somebody who evaluates drug trials would say, yes, but did selegiline have an effect compared to placebo? So in other words, they may both just have gotten better because of everything you did. In the trial in cats, it was randomized, double-blinded, placebo-controlled, multi-center, 17 cats in each group. The complaints were various and all over the map. Again, there were days 56 and day 1, similar to the dog study. No differences between the groups except for interactions with known and unfamiliar people. And the owners reported that the rate of change of autonomic signs was different. Okay, so I would look at both of these sets of data and I would say this is worth a good study. These were bigger samples. They at least randomized them and they blinded the groups. That takes away my larger concern. Multi-center studies are always a problem. I hate them. I analyze data for them, but I don't like them because you end up with small samples in each group. But at the same time, they did show some findings that in a better study that's more controlled, it would be worth evaluating. They also have a good mechanism of action. There are no published, peer-reviewed published studies at this point in time. Composure, Soliquin, Common Care by Nestle Purina, or the intervention, the Assisi, the Calmer Canine tool. So what's a placebo and why am I so distressed about this? And I want you to think about those data, I've got to go back, those data that we just talked about compared to the pharmaceutical data, and which set of data, if this is the beloved dog or cat of your life, do you want to rely on? And what's seldom appreciated or articulated about having a placebo is it's not giving a sugar pill. That's not what we're doing here. What's seldom appreciated or articulated is that when accurately measured, the placebo effect is a valid measure of the variance of the effect of the trial or the study itself, regardless of the placebo's focus or the mechanism of action. The importance of including a placebo treatment in an experiment is that the existence and magnitude of a statistically significant difference between the response of the treatment group and that of the placebo or control group in an experiment provides evidence for efficacy of putative treatment. And in short, we have a way to assess our intervention, but we seldom interpret our results in this light. The people who design the studies do interpret them in this light. But this is how we now have to think. We need to begin to do so because when signs are non-specific, not equally noted, and may be infected by client interpretations, we need to evaluate the effect these factors have on our findings, and we published that in 2009. Okay. Now, I said I'd come back to one study about L-theanine, because this was their conclusion, which showed me they didn't understand what a placebo effect is and don't know how to do the experiment correctly. And clients pay the price for this. Conclusions. Despite a lack of a placebo group, it can be concluded that L-theanine helped to improve the undesirable manifestations of stress in cats as soon as 15 days, though better results could be seen after 30 days. These encouraging results show that L-theanine can help manage stress-related behavior, and additional trials with a placebo group should be run to confirm this effect. Absolutely not. No statistician worth his salt would allow you to even say this. I don't know why the editor didn't reject those words and make them change their conclusions. They should have. So should their reviewers. But people are busy, and they're not reading these papers as carefully as they should. But that's just bad science. So what about diets? Diets don't go through the regulatory process, but the manufacturers are pretty careful. They're really trying, excuse me, try air. They're really trying to hew to a mechanism of action, and they're very careful about stepping over the line about drug diet. The data are better for supplements, but the sample sizes may still be small, and some studies are better than others. Hill's BD, which is short for brain diet, has antioxidants, free radical scavengers thought to encourage BDNF production for learning. And lab studies have shown this, contains bioactive compounds that may act as precursors or enhancers for some neurochemicals. And there are really good data that it has effects. And it's being published in a number of studies. Purina NeuroCare, which is the most recent of the diets, same line of diets as EN, the enteric diet and Bright Minds. They all have beta hydroxybutyrate in them. Beta hydroxybutyrate protects hippocampal neurons from assaults and protect membrane integrity from beta amyloid toxicity in cell culture. There are excellent papers about this. The medium chain triglycerides that they use act as a source of fats and ketone bodies that help you with the beta hydroxybutyrate to sequester glutamate. So you damp down that reactivity, you damp down that impulsivity. Remember that when we were talking about drugs that affect glutamate, mepitoin, gabapentin, same general idea here, and there are excellent dog papers if you want to read them. These all should be in the public domain by now, and if you can't get them, send me an email. I'd be pleased to send you the paper. But Google Scholar should have most of them readily available. Royal Canin Calm Diet has alpha-casozepine in it. Remember, this is the compound I said there's enough here that you really need to do a big study. Antioxidant complex of lots of things, including lutein, which we know is good for protecting retinal neurons and improving retinal function. It's intended to be fed to dogs 10 days before an expected stressful procedure and kept on it. The data are not perfect, and you can read the papers, but there's enough there to suggest that this may help, and it's an intervention that you can combine with other interventions. So where should we go from here? You know, I basically said the diet data are better than the supplement data. The supplement data are actually quite poor. The idea that they are risk-free is false, and the idea that you're medicalizing behavior is also false. So where should we go from here? Well, here's what our original premise was. We want treatment to be humane, but shouldn't treatment work? And that's our question. There's strong evidence that most of the medications discussed work, given the criteria we established at the beginning, but some have strengths that others don't. And with imepitoin, we're a little worried about the sedation and ataxia role, which is a concern. The data for diets are good, but limited in terms of application, and the supplement data are pretty poor. With behavior modification, you can actually see changes quickly sometimes, and over time, concomitant with effort, although people really too seldom follow behavior modification protocols in a standardized way, unless they're doing a study. So we lack data about behavior mod. Studies have shown that it works, okay? But we lack the studies that we have for medications. Now, here's my question for you. Does humane treatment require that we do not delay known efficacious treatment in time-penetrant conditions? All behavioral conditions, all pathologies worsen with time. Should we be having a discussion of the long-term cost of the decision you make in treatment with the clients? I want you to think about what the goals of the interventions are. Are they to alleviate a global assessment of anxiety and suffering? In other words, alter the client opinion? Are we objectively altering signs associated with distress? Are we giving the clients a measure of patient behavior? I give my clients a measure of patient behavior to evaluate, and I want to see the evaluations, and we use video. To help patients learn to help themselves by altering the way they react? I really want to see that, and I understand if clients aren't happy, we're not going to find out about any of this. But what are our goals? I tell clients that these last two are my goals. No one talks about these issues, but I think we need to if patient-centered humane care is our focus. Because that's not what you get in these efficacy studies. And the world is more complex than that. We're treating real patients in front of us. We need things that work in ways that are meaningful to their lives and can expand their lives. And I think that when we use behavioral medication, we're creating an effective, scientifically based, data-driven, multifocal, and integrated humane treatment program that respects everyone's needs. Remember, these drugs affect behavior modification. They speed it up. One of the outcomes of the Clomicalm study was that it enhanced the rate at which you required behavior modification-based changes by 3 times, 300%. difference. Life can be less difficult for our patients, and we'll all benefit. And what I'm really looking for is our patients to change us for the better, to make us think a little more deeply about what their needs are. And I want them to experience joy. And that's really what I want, one of my recent patients. So there are resources. You can email me, Twitter, my website, which has a lot of handouts. This is what the journal looks like. There are now many, many, many organizations that are affiliated, so discounts are all over the place if you want to subscribe. And the next webinar will come up and we'll talk about the literature. So I'm going to stop sharing my screen unless there are questions specific to slides. And I see there's Q&A and there's chat. Are there contraindications for prescribing Trazadone for fear-free visits in dogs? Okay, the first step there is, and they gave a 7 to 10 milligram range, and you were just a little over the dosage range that's cited in the literature. There are two concerns that I have, and I'll tell you when I use Trazadone. I use Trazadone for animals who are hospitalized and need to be quiet in a run or a cage in the hospital, because then I don't care if they're sedated. I don't use it the same way I use benzodiazepines, oral transmucosal dexmedetomidine, and gabapentin for coming into the hospital, because I don't want those patients to be sedated. I want them to learn they can have a great experience. So my concern is that at some of those dosages, we may be sedating some of the patients. And if they are taking any other serotonergic drugs, that's a high enough dose that we need to be mindful of cardiac effects. All of my clients measure their dogs' heart rates, and they measure them when we first start meds. They periodically take a week and measure them again. Why? Because the first signs of serotonin syndrome are an increased heart rate, and they can find that out for me, whether their dog or cat is at risk. Would you ever use fluoxetine baseline and situational usage of Trazadone in separation anxiety dogs? So obviously what they're asking here, Catherine's asking a lot of questions. Fluoxetine as baseline. So that's your daily drug. And then Trazadone situationally. I likely would not, and I'll tell you why. Because I'm seeing in my referral population patients that are coming in on very, very, very high fluoxetine dosages. And the study that was published out of Cornell a year and a half ago showed that dosages of 0.5 to 1 milligram per kilo are substantially better than higher dosages, and you don't get as many of the adverse effects. So I'm seeing patients who come in often on very high doses of fluoxetine. I know a lot of people do use Trazadone in that setting for separation anxiety. I would not. I would use, again, a benzodiazepine, Cilio, gabapentin, things that will help you to learn, and I don't have to worry about sedating you, and I don't want another serotonergic drug necessarily in there. And part of the problem is that if dogs are not doing that well on an SSRI, I'll often combine an SSRI and a TCA, and in that case, I really don't want another serotonergic drug in there, even though I've lowered the dosages of all the other drugs. Unless I'm concerned about controlling movement and I want that hypnotic effect, I'm going to stay away from Trazadone. Do you have any experience with valerian root extract? Actually, years ago, yes. And there are some good data on valerian root extract. They have not had the extensive studies that they really need to have, but they may act as a benzodiazepine type analog. And that's one of the compounds that really should be further explored. The problem is that when we're dealing with extracts and herbal compounds, this sample isn't the same as this sample, isn't the same as this sample. The Canadian Veterinary Journal this year published a paper on all of the cannabinoid products that are available in one region of Alberta, and they just analyzed them. And honest to God, no two were alike. And that's the problem we tend to have with herbal compounds. Do we have evidence that gabapentin is anxiolytic in dogs? There are no placebo-controlled double-blind studies for gabapentin in dogs, period. And that's something that really should be done. There is evidence that gabapentin has anxiolytic effects in other species. Dogs should really not be any different, but that study has not been done. I've had many clients with questions about CBD products. Do you have any opinions or experience with any of these products? Well, my entire experience with these products is that every single one of my patients has taken them, it seems lately. I don't have any experience with them, and I am loath to prescribe them, and I would follow the AVMA's caution to veterinarians to consider very seriously the extent to which they want to be involved in prescribing these, given that they don't meet any of those criteria for efficacy that I just set out. Would you prescribe a lower dose of Trazadone for scenarios where the animal may have an aversive experience, like at a groomer? Now, a groomer, you might want to have them sit still, so that may be an appropriate place to prescribe a lower dosage of Trazadone and to see if it helps that individual dog. Remember that sedated, if you get a sedation effect, it impairs learning, and in some cases, the impairment of learning can augment anxiety. This is one of the problems with aspromazine. You're sort of disoriented in how you put together information, and in some animals that will make them a little more anxious. And if what you want to do is facilitate learning, bear that in mind. What dose of gabapentin do you start with for vet visits? Okay, the dosages that are widely used, and I'm going to quote the college listserv here because a lot of people are now doing this. I start at 10 to 20 milligrams per kilo to start and see how they do. And we often have these staged visits so that they go through a trial visit so we can see if this is a good dose for the real visit. Certainly people have gone up to 30 to 50 milligrams per kilo every 8 to 12 hours. That's in line with the dosage range that has been used in humans. Note from Chiara Pariti. Thank you. It's important to highlight that seeking attention can be a sign of stress, and behavior mod should not modify it on purpose, but the dog should decrease it because they don't need it anymore. And I do agree with that. And that is why I was saying we have to ask whether the dog can use what we're giving them to help create their own way of making the situation more amenable to them. That is very different than what we're traditionally doing. And I think Chiara's concern is if we're suppressing attention seeking, we're suppressing them telling us that they're distressed. No, no, no. I want us to respond to their distress, and I want them to have medications on board that will help us to create a solution to that distress. Great question to end this with, Chiara. Absolutely wonderful.